Hello, my name is Zigmond Kozicki, and this is The Accident. Today we're focusing on some of the medical treatment or interventions that take place after a person's been involved in an auto accident. I want to share some facts with you first before we begin and have an opportunity to hear our guests tell us their expert opinion. First of all, every year nearly 40,000 Americans die from motor vehicle related injuries, and another 270,000 are hospitalized in the United States. What we have in this large number is many people who need some kind of emergency department services. In fact, most people end up in the usual emergency department if they have a mild or moderate injury. Some people end up in a level 2 trauma center if their injuries are more severe. Trauma centers like this have the equipment and needed help to take care of severely injured patients. Most regions have several trauma centers which are part of a network to help people when they are in these serious accidents. Along with trauma centers, what we have is a network of rehabilitation. And in the state of Michigan, most of the community hospitals have a rehab department that provides primary care, specialty care such as neurology, physical rehabilitation, and mental health services, all of which are necessary after a person has been involved in a traumatic event such as this. What we try to do, and many times are successful, is provide pain management to patients who are going through their medical care. But there are other things that people require. This includes legal services. Quite often people have complications that require an attorney after an accident, as well as financial services, sometimes brought on by the cost of medical or the changes in income that might come as a result of being disabled. And in many cases, people need family daily living services if the person's injured and the family is no longer able to take care of the person. And there are occupational services, which might be necessary if the person is to return to work or to learn new skills to take care of their daily life. So all of this is a package, and the people who provide this are diverse and oftentimes focus in on the patient. I want to introduce my first guest here. Keith is a person who was a patient and can tell us a little bit about his experience with the medical community.
Well, I'll start by saying that in September 7th of 1978, I was involved in a serious motorcycle accident that brought me to the hospital with numerous injuries, one being a closed head injury. I had 5 broken vertebrae on my spine, which over the years has led to 11 surgeries and ongoing problems as a result of that accident. I wouldn't be able to be here today and talk as fluently as I am able to if it wasn't for the assistance that I received through the years to present time. I was 38 years old at that time. Today I'm 70 years of age, and it's been an ongoing process to get to where I am today. So I'm very grateful for all the help that I've been given. However, I also feel strongly that much of what I believe is my recovery to a large degree is based upon my ability to want to participate and make the effort that is required. Because when I started out, I was told a lot of things that I couldn't do. I was going to have difficulty with this, I was going to have difficulty with that. I've gone through a lot of different programs, cognitive training skills, the pain management programs, and I've been very heavily involved in personal recovery through physical therapy to get to where I am today. So I have a great deal of gratitude for for where I am, and I'm very thankful.
Thank you, Keith.
Thank you.
Dr. Dardis, as a medical doctor, you probably have a view of the auto accident victim, survivor, from personal experience as well as professional observation. What kinds of things do you think people should know based on your expertise or observations?
Well, one of the key things to remember is that many times after an accident, when a person comes to the emergency room, there's an initial triaging where many radiologic studies are performed, and oftentimes very serious head injuries can be missed as far as CAT scans and MRIs. The more dramatic ones involving skull fractures and people needing surgery are usually pretty obvious, and yet many times people will have what look like normal CAT scans, normal MRIs. This can be the source of a great amount of confusion and frustration for patients and families and their doctors, because a lot of the injuries are just not showing up on those scans. There can be subtle injuries that just escape detection by the current MRI and CT techniques, and therefore this has been an ongoing source of trouble. I think the other issue that Keith brought up was the issue of rehabilitation. When I was in medical school, 1987 to 1991, we were still at a phase where we thought that everybody was born with the same number of nerve cells that they're going to ever have, and that the cells don't divide. Well, we subsequently have learned that there's a lot more plasticity to the brain, and that the idea of focused, passionate learning or intentionality on the behalf of the patient makes a big difference. So, you know, we really don't like to put upper limits on what people can achieve, especially for injuries that occur a long time ago.
It's a good observation. Speaking of physical therapy, Catherine, this is what you do, right?
That is what I do, yes. In conjunction with physicians and with our other medical team, physical therapists along, and particularly with our automobile accident patients, we tend to work in a team along with our colleagues from occupational therapy and speech therapy. A lot of people that undergo particularly head trauma have not only physical disabilities, but they also have cognitive disabilities, speech disabilities, and combining all of those disciplines together with therapy is really where we find that we have the best effects and the best benefits for the patients. We have to remember that therapy doesn't just occur in the hospital when the patient first is injured. It can occur, you know, we can start therapy then, but it is an ongoing process through many, many years sometimes. For some patients it can be, you know, a 30-year process depending on coming and going in and out of therapy over those years. And lots of different settings. We have therapy that is done in the hospital, but then also therapists coming into the home if patients aren't able to get to therapy, outpatient therapy, and then there's specialized facilities for group therapy and combination therapy as well. So it's a very diverse field that is based very much on the patient's needs, depending on what functional level we're looking to get them back to.
Now, Keith said something about he was motivated and he had a goal or a mission to get healthy again. What happens if you have a patient that isn't that way?
It makes our job much harder. If the patients don't buy into what we're doing and don't follow through on their own time, then the outcomes are not going to be so good. We need the patient to follow through with the instructions and do the homework that they're provided and that they're given to help get the maximum benefits.
And many times that might be painful.
Absolutely. Therapy is not always fun, and I think Keith would attest to that, particularly the patients that have physical disabilities. If we had fractures, spine injuries, we have a lot of patients from automobile accidents that have a lot of chronic pain, particularly back pain, neck pain, that does hamper their therapy sometimes, but with appropriate management and good skilled therapists, we can work with that and help them through that with the understanding that there is a benefit involved. And with the patient assisting us and our physicians assisting us with pain management, that certainly makes a huge difference.
Okay. Dr. McInnes, Dr. Dardis alluded to the fact that not all head injuries and trauma shows up in the CAT scan or the MRI. Is this a place where psychometrics and the whole neurophysiology shows up in the neuropsych evaluations?
Yes, Fortunately, most head injuries and accidents and falls are mild, but as Dr. Dartis mentioned, in that kind of an injury, it's very unusual for a CT scan or an MRI scan to look abnormal. The injury is happening really at the cellular level, at the neuronal level, and that kind of injury doesn't appear on a scan. Our current scanners have resolutions of about 1 millimeter. Well, if you take a box 1 millimeter by 1 millimeter by 1 millimeter, you're talking several tens of thousands of neurons. And so you could have a lot of damaged neurons and yet it still looks normal. So the function may not be right, but the structure looks okay on the gross level of a scan. The common problems that I think most people will experience, I think probably the most common problem that people will experience early on is problems just with attention and concentration. They have trouble with focus and maintaining attention, or they get distracted easily. They can't have the television on and have a conversation at the same time, that kind of experience. And then that also frequently leads to problems with people's short-term memory. They're not retaining new information very well. The patient may be repeating questions, or they may be repeating themselves. And then that leads frequently to a lot of problems with family members, because it sets the person up to be in arguments because, well, you didn't tell me that. Yes, I did. No, you didn't. Yes, I did. There's that kind of phenomena going on. Or they become suspicious about what people are telling them because, oh, I wouldn't have said that. Why are you saying I said that? You know, and so then there's that potential for problems. And then the other issue I think that's very frequent with people with head injuries, even the mild ones, is people really don't recognize that they have a problem. Particularly early on, there's sort of a lack of insight that they're in a hospital, laying in bed. Maybe they have a lot of physical injuries and they hurt, they know that. But, you know, I always tell people it doesn't take a lot of neurons to be a patient in a hospital. You lay there, the hospital nurses come and give you your medicines, and somebody brings you your meals, and your family's attentive, maybe hovering around you, doing everything, and you don't really recognize that you have much of an issue. It's not until you get into a more demanding environment, maybe you go home or you go to rehab and, geez, you know, a little more of an issue here. But denial is a wonderful defense mechanism, and so sometimes, you know, I don't want to be this way, you know, so no, I'm not really like that. And so you get that combination, plus the person themselves really doesn't recognize that they're forgetting, and so it must be your problem, not my problem. And so sometimes you do have problems with patients' motivation because I really don't have any problems, and my doctor told me I'll get better, and so I don't really need to do this. And you know, you hear a lot of different variations. And then I think one of the other really big important factors in terms of predicting who's going to get better is the family. You know, do they have an intact family support network? Because it's the people who have very dysfunctional backgrounds or very not much of a support system. Those are the people that really have the hardest time getting better because they have so many needs that they can't do it on their own.
Yeah, that's a good summation. And I know that from my own experience in working with pain patients and post-traumatic patients, that many times they're surprised that they have a problem until they're actually talking to another person who has a problem, but has progressed along the way and has some new insights to share. And then the person starts to realize, you know what, maybe that's happening to me also. So I think that that's very true.
Well, I also think that sort of the Midwestern ethic, you know, we're going to I'll gut it out and do it myself. And I don't want to be a whiner, you know, and people don't want to complain. You know, people ask you, how are you doing? The natural say, I'm doing great. And the people around you want you to do great. Yeah. But it's not often honest. You know, I always tell people, don't tell people you're doing fine. Tell them you're getting better.
Yeah.
You're not 100% yet.
Well, this is an interesting segue into something that's going to take place in America with the new Affordable Health Care Act patient involvement and actually empowerment is one of the goals of evidence-based medicine in the future. And it's actually asking patients to become more directed, more responsible. And I guess going back to what Keith said earlier, Keith, you know, why is it that you found yourself wanting so much to get better? Was there something special that was going on for you?
Well, first of all, I'd like to say everything that I've heard so far I can relate to, so I know I'm in the right place. But the thing is, when your inability to recall things that you were doing before, or the ability to make decisions as you were used to, I managed 50 people, made a lot of decisions. I was very visible. And then, boom, all of a sudden that changes. People aren't coming up to you and asking you how you're doing. And you find yourself confronting yourself and you say, what am I going to do with the rest of my life? Or what am I going to do with the situation I'm in? And like the doctor said, this didn't come about, you know, 2 weeks after I had this experience that I said, oh, I got a problem. It took about 5 years before I realized I was way over my head, that my inability to recall things, to make decisions, and other things that I was struggling with. However, on the other hand, you're at a crossroad. You say, do I want to go on, or do I just want to throw in the towel? Those are, you know, for me, speaking for myself, that's where I was at. And it was also alluded to here, this support. And this is where I feel very fortunate. I have a spouse who was tremendously encouraging to me and non-judgmental, and that played a tremendous role in my day-to-day activities, even getting to where I am today. Because not all things, I may look fine and I may speak well, but I still have difficulties, and but I know those signs and I know what to do. So I guess, and I don't know if I'm answering your question specifically, but it really comes down to, are you going to participate in your wellness? Do you want to, you know, I can get the guidance, but how much do I want it? And I wanted it a lot, and I still want it today. So each day I look upon as a gift given to me, and what am I going to do with the rest of this day?
Very good.
So.
Dr. Dardis, I know that from a standpoint of your medical training, you probably have a perspective about Keith or anybody else that has probably been honed by all of the research and the developments that we've taken place over the last 20, 30 years. How do you feel about the future for healthcare in these areas? Do you think that we're going to continue to progress along some certain path in terms of rehabilitation?
Oh, definitely, because I think, as I mentioned earlier, there's an increased recognition of the plasticity of the central nervous system. And as Keith has mentioned a couple of times, I think it's kind of one of those chicken or the egg questions I'd ask patients. I say, those that can engage in active, passionate, genuine new learning, we really encourage that. And to get to that point, we have to have attention, because attention is very much linked to memory and so forth. So all of this is jumbled in together, and as Dr. McGinnis said, a lot of times at first there's a distractibility factor and they can't really concentrate. So I think we have to figure out how to streamline this so we can capture the person's attention first and engage them in new learning, and they have to be actively involved. They have to want to do it, because simply going up to somebody and saying, okay, we're going to do these math problems and we're going to memorize the capitals and so forth, that doesn't seem to work. It has to be a patient-initiated type of learning to really get the most out of a recovery. So I think we're learning more and more and more about that, and I think as we get better models as to how to link into those pathways quicker, I think we're going to see quicker results and better results.
And Catherine, that's what you come up against all the time, isn't it?
We do, yeah. We come up against lots of different motivation levels, and people that have head injury, we have difficulty with attention and memory, and so how do we get them to follow through and participate in their rehabilitation, and whether that be from a physical therapy or speech therapy, cognitive relearning, things that we're doing. If the patient is having a hard time following directions or sequencing their movements, then how do we get them to do that better and to encourage them to participate with us? And it's very, very important that we use all of our skills and that we talk with our colleagues that are also dealing with that patient and work closely as a team. It's very much a medical team. It can't be individual therapies. It has to be a team with the neuropsychologists, the physicians all involved, because that way we get the most out of the patient, so that everyone's working together and really working with that patient to meet the patient's goals. And I think one thing that we really have to work on is really finding out what are the patient's goals. What is it that patient wants to do? Because what I want the patient to do isn't necessarily what that patient wants to do. So if we can really get to know that patient and develop a good relationship with the patient, then we definitely see much better outcomes.
Well, all of you have added comments. What kinds of advice would you give to family members or those people who are going to have to deal with somebody who's been in an automobile accident? And maybe we'll start with you, Dr. McGinnis.
Well, I think one of the things that's most important is for the family to begin to reframe a lot of times what the patient is doing as often a symptom of their injuries. For example, a common scenario I find with many patients, because they have problems with their memory, they may go into Myers, the grocery store or whatever, and they run into somebody that they know, and they've known for 20 years, and they can't remember that person's name. And then the person interprets that as, this person doesn't care about me, they're a jackass, they're stuck up, they have some negative connotation about that. And if they would understand, no, this is a symptom of the person's injury, oh, okay, they would have a very different response to the person's interaction. And that goes on with family members all the time. And the families usually get the worst of it because, of course, the patient is in rehab all day long and they come home, they're tired. And what are we like when we're tired? Well, we tend to be irritable, short-tempered, and so the family gets the brunt of all that every night. And so you have to work with the family to help them understand, no, this person's not being a jackass. This is a symptom of their injury, and here's how you can cope with this. One of the common problems with people with memory problems is you're trying to give them more information. Oh, no, this is what we, and it's like, no, you want to give them less information at this point. Mm-hmm. It's not the time to confront somebody in an argument.
Keith agrees with you. He's nodding over there and saying, yep.
That's for sure. The thing is, again, what I'd like to point out, when I had this accident in '78, a lot of things we're talking about really weren't known at that time.
That's true.
So I went through a period where I was really trying to keep my head above water, swimming, but I was making real good time, but I didn't know where I was going. And the thing that the doctor talked about, even today, I was sitting here, I carry a notebook. You probably noticed that when I came in, but I write things down so I stay on track. Because when he talks about short-term memory, no matter how hard you work to improve your skills, certain things you're going to go with forever. So.
We've got a couple minutes here. Dr. Dardis, would you like to add anything to the stew that we've been making here?
Well, I think you touched on the family's involvement, and I think that's very helpful. That always, whenever you're building new habits, new programs, you need as many friends and as much of a secure network as possible. And I think if the family is educated as to the natural flow of things, they'll be less bothered by some of the personal behaviors and the seeming absent-mindedness, and probably will help to encourage without enabling some of these problems and their progress. So I think the more education of friends and family you can give, I think that probably would correlate with an improved outcome.
Now, Catherine, many of the physical disabilities or injuries are a challenge, aren't they?
Yes, people that are involved in motor vehicle accidents can have multiple physical injuries as well as the cognitive injuries, and that creates its own special challenge because we're dealing with a lot of different things that can be involved that can result in pain, physical disability. Maybe the patient is wheelchair bound for a while, so that in itself creates other psychological issues that we have to deal with, as far as depression, not being able to do things that I used to be able to do, maybe can't go back to work. So we have to work not only with those physical disabilities, but how does that affect the mental status of the patient, and how do we kind of counterbalance some of those physical disabilities.
Okay. Well, I want to thank my guests for joining us and for sharing this information with you. Hopefully this will be useful information, and in some way maybe it will even help you should you or your family have an accident. And I want to point out that this is a public health series that is intended to provide information to you and the community about people who've been in accidents. And maybe the next time you meet someone or you have some personal contact with somebody who's been in an automobile accident, you may want to pause and think about what they've gone through, and that they're probably still working very hard to gain back what they've lost in that traumatic experience. So once again, I want to thank you, and I want to thank all of the people who participated in this series, and most importantly, I want you to drive safe. Take time to make sure that you know that driving should be your first priority. Thank you.